an hour almost. Just I request the winner of the previous session, Dr. Vishal. Dr. Vishal, please, you can start the session, and after that calculation, I invite the second one, please.
Dr. Vishal.
Please start. Audio visual team, please. Dr. Vishal.
Yes. Okay. So good morning, one and all. So I'll be presenting an interesting paper on the ERG changes in the inner and outer retinal layers before and after intravenous chemotherapy for retinoblastoma. So as we all know, retinoblastoma is the most common intraocular tumor in children, and the current most standard of care for all the children with retinoblastoma, particularly in a low resource country like India, is intravenous chemotherapy. However, we all know this chemotherapies are kind of toxic, not only for the systemic toxicity but also from the intraocular aspect, and the numerous reports of ERG following intra-arterial as well as intravitreal chemotherapy have been published. But the ERG findings after systemic intravenous chemotherapy, which is the standard of care in India, is not very kind of presented or limited. So with that purpose, we wanted to understand whether giving intravenous chemotherapy, especially in children with retinoblastoma in a country like India, do they affect the global function of the retina, especially the inner and outer retinal function. So this was a prospective observational study done at LV Prasad Eye Institute, Hyderabad, with the inclusion criteria of all the children diagnosed with retinoblastoma. The data was collected in terms of demographic, clinical features, as well as fundus photograph, including our RETCAM imaging. The methodology what we use currently in our institute is giving intravenous chemotherapy using standard 3 drugs, vincristine, etoposide, carboplatin, every 3 to 4 weeks for 6 cycles. The ERG testing was kind of novel. What we used in our setting was the RAVAL system, which is LKC handheld technology, where we use this technology to image or record the ERG findings in children under anesthesia, both pre and post chemotherapy. The standard ISA protocols, both from the photopic, flash, flicker, as well as PNHR readings were calculated both pre and post, as well as the outcome measures were demonstrated in terms of flash ERG, peak times pre and post, compared with the normal contralateral eye, and the measurement of PHNR amplitude and the PNHR ratio at 72 milliseconds. Just to give a brief understanding what all things we measured as in terms of quantitative measurements of ERG, one is the implicit time, that is the time from stimulus until the peak of activity, both for A and B wave, as well as the amplitude, both for A and B wave. In terms of result, we have total of 6 children, 12 eyes included in our study. 4 children had a unilateral RB, whereas 2 children had bilateral RB. One eye we had to exclude due to primary enucleation. However, the other eye, which was a normal eye, we included in our study. The mean age at presentation was 3 years, ranging from 1 to 5 years. In terms of tumor classification, 1 eye had group B, 3 had group C, and 4 eyes had group D retinoblastoma. Important confounder, particularly in ERD setting where we want to look at the macular function test, 7 eyes had a pre-existing macular involvement of retinoblastoma, as well as 5 eyes had associated retinal detachment and subretinal fluid. In terms of finding, the tumor regressed in all the 7 eyes with retinoblastoma, that's showing 100% response to a standard intravenous chemotherapy. In terms of ERG changes, as you can see in the light adapted, that is A wave and B wave peak time, it kind of delayed in 2 eyes in A wave peak time, whereas in 5 eyes in B wave peak time. In terms of amplitude, I think it kind of decreased in both A as well as B wave in 5 and 6 eyes respectively. Important finding what we could see, there's PNHR finding, which is a specific retinal ganglion cells, which was improved only in 1 eye, where it is decreased in 6 eyes, whereas the PHNR P ratio was improved in all the 7 eyes. So this is a couple of cases where you can see in the patient presented with group D retinoblastoma after 6 cycles of intravenous chemotherapy. There was type 3 regression. Pre-intravenous chemotherapy, the ARG amplitudes are totally flat, whereas post chemotherapy you could see there was a improvement in the amplitude as well as the latency in the A as well as B wave. The another patient where you could see there was a macular location of retinoblastoma, and after 6 cycles of intravenous chemotherapy there was type 3 regression of the tumor. In terms of ERG findings, you could see there was a reduction in the amplitude as well as the increase in the latency for A and B wave, thereby demonstrating that the macular location of the retinoblastoma might be detrimental to future vision potential in these children. The key findings, the normal contralateral eye, there was no detrimental in terms of retinal function except in 1 eye, and there was no statistical difference between the study and the normal eyes in ERG at follow-up. In terms of visual acuity, because we all know these are pre-verbal children, it will be very difficult to measure visual acuity in these children. The central fixation of the child improved only in 1 eye, whereas poor fixation in 2 children. In terms of discussion, more than 50% of eyes showed delayed photopic flash and flicker responses after chemotherapy despite tumor regression. There was improvement in only one eye, indicating poor recovery of retinal ganglion cells and amacrine cells, and intravitreal chemotherapy had no detrimental effect on the normal contralateral eyes. To conclude, I would say intravenous chemotherapy effects on the retinal function are very complex, and it needs to be influenced by other important confounders like macular location of the tumor and associated retinal detachment. The inner retinal functions, especially PNHR waveforms, improved only 1/5 of the eye, suggesting a long-term effects on the vision development and need for early visual rehabilitation. In terms of future research, we recommend longitudinal studies to comprehensively assess retinal function as well as the vision development in these pre-verbal children, particularly in patients with retinoblastoma post-intravenous chemotherapy. Thank you.
Very nice work. So, were they all receiving just intravenous, or anyone received intraarterial or intravitreal also?
No, so the inclusion criteria was to just to look at the intravenous chemotherapy. After 6 cycles, if there was a recurrence, then but obviously they use adjuvant focal treatment like TTT or even intraarterial chemotherapy. But the limitation of this study, because we wanted to study the effect of chemotherapy, that is especially systemic chemotherapy and pre and post ERG findings, because intraarterial we know it causes detrimental loss of retinal function because of the targeted localization of the drug into the retina and choroidal compartment, and intravenous chemotherapy, again it is published, melphalan causes salt and pepper retinopathy. So I think that is all published. Intravenous chemotherapy, it is not published or it is not known. So that's what we wanted to study from our paper.
And they all got standard dose chemotherapy,
Yes,
6
standard.
cycles,
Yes,
all
yes,
of them.
yes, yes.
Okay, thank you.
Thank you.